right? Those are the words of our governor in creating this role. And BT Dubs, that's my job description, no pressure. But as I came into the role, I had the opportunity to work with the governor's office in really establishing my priorities as our first Surgeon General. And the three key priorities for the Office of the Surgeon General are health equity, early childhood, and adverse childhood experiences and toxic stress, right? And you'll notice that, these things are related. But it's really my joy to be doing a deep dive into these areas, working with the leadership of the Newsom administration and with all of you, right, to advance how we're doing. So I know that you all are in this, many of you are reading the book, The Deepest Well, Healing the Long-Term Impacts of Childhood Adversity. I cannot tell you how happy that makes me. But because we have kind of a broader audience, I want to start by, I always like to ground, right? So to make sure that we're all in a shared understanding. And to start with an understanding of, what are ACEs, what are the ACE study, and what are the impacts, right? As you all likely know, right? The 10 traditional ACEs include physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce, or domestic violence, right? And these are the criteria that were studied in the landmark ACE study that was conducted in partnership between the CDC, the Centers for Disease Control and Prevention, and Kaiser Permanente. And I want to recognize that these ACEs, right, they don't include things like discrimination, right? They don't include things like being separated from your parent or caregiver because of migration or deportation. But what was interesting, these original criteria were created because the principal investigators were doing the study in a population that was 70% Caucasian, 70% college educated, right? They were members of Kaiser Permanente. They were all privately insured, right? And what the study found was really striking. So there were three things. The first is that ACEs are incredibly common. In that original Kaiser San Diego population, 2/3 of folks had at least one ACE, and 1 in 8, 12.6%, had 4 or more ACEs. Here in California, we see that based on the latest data from the California Department of Public Health, we see that 63.5% of Californians have experienced at least one ACE, 17.6% have experienced 4 or more ACEs, right? The second thing that the study found was that ACEs touch all communities, whether you're upper income, lower income, every race, ethnicity, every geography is impacted by adverse childhood experiences. And when we look across our state, we see that every county is impacted. In fact, it's our rural Northern California counties that actually are most severely impacted. Butte County is the #1 highest prevalence of ACEs in California, right? And in Butte County is 83% Caucasian, right? So we see that it's every race and ethnicity, every socio-demographic strata, right? But at the same time, one of the things that we see is that, as reflected in the governor's comments, that our low-income communities are disproportionately affected, right? So when we look at national data of ACE prevalence by income level, for individuals who are low income, meeting the poverty level, we see that the proportion of ACEs is much higher. So those not in poverty, income greater than $50,000 a year, 13.2%, very, very similar to the original Kaiser data. But for those who were in poverty, right, the prevalence of 4 or more ACEs was double, right? 27.6%. That's more than 1 in 4 individuals. The third finding that we learned from the ACE study was that there was a dose-response relationship between adverse childhood experiences and some of the most common and severe health outcomes in our society. So when we look at the 10 leading causes of death, if anyone's ever seen me speak before, like I used to say, oh, ACEs are associated, strongly associated with 7 out of 10. And then it was 8 out of 10. Now we have the latest data from CDC released yesterday. Now we have data 9 out of 10, right? Of the leading causes of death. And I'm, pretty soon we're going to get some data on influenza and pneumonia and who knows, right? But what we see is that having 4 or more ACEs dramatically increases the risk for 9 out of 10 of the leading causes of death in the US, right? So we recognize that here in California, 17.6% of our population has 4 or more ACEs. And if you have 4 or more ACEs, there's a significantly increased risk, right, for 9 out of 10 of the leading causes of death. And why do I raise this? Because it's very easy to look at this slide and feel so apprehensive, right? It can feel like gloom and doom. And part of the reason I raise this is because one of the things that's so important about this is when we clearly understand what this points to is that early adversity is a major driver, not just of morbidity and mortality, but also of healthcare costs, right? Because the question is, listen, we're all strapped. Where are we going to get the resources? How are we possibly going to put the infrastructure in place to systematically reduce and mitigate ACEs? Well, how much money are we spending on heart disease? Because if you got 4 more ACEs, you got double the risk for heart disease. So if we're talking about heart disease prevention, preventing and mitigating ACEs needs to be at the top of the list. Right now in the US, we spend $3 trillion per year on healthcare costs. And 75% of that is for treating chronic diseases, right? We need some of that money for preventing and mitigating ACEs. Because what the data shows us is that ACEs are not destiny. And with intervention, we can make a significant impact and improve outcomes. But how are we going to do that, right? So when we think about, like, what is our roadmap? How do we understand a strategy for addressing and mitigating ACEs? Well, this is the place where the full science nerd in me comes out. You guys, I gotta tell you, there are few things that I love more than science, medicine, and public health. I don't know if y'all know, for those of you reading my book, you might have read the part where my dad's a biochemist, right? And literally, when we were kids, my dad and I fully bonded on, like, playing science games, right? Like when I got, my family's Jamaican, so we eat a lot of curry. I got a curry stain on my white blouse. And of course, there I am. I'm so upset. I'm trying to wash it out with a bar of soap, right? And the curry stain turns from like a bright yellow to like a purpley pink. And I'm just like, holy mackerel, this blouse is ruined. And my dad, right, he's like, oh, curry is an acid-base indicator, right? This is like how I was raised. So thinking about how we apply the science to the world around us, right, that's my jam. And when we take a look at a great example, right, let's look at HIV/AIDS, right? What we've done in the US as far as HIV/AIDS is, in the past 30 to 40 years, right, has been one of the greatest public health successes, right? So back in the day, early 80s, I'm looking around a lot of young folks here, so y'all aren't going to remember this, but I'll have to recount it for you, right? Actually, I was in elementary school, but early 80s, doctors were seeing patients coming into, you know, emergency rooms and into our offices, right? And they said, oh man, okay, this patient that got TB. TB, I know how to treat that. All right, here you go, I'm going to write you a prescription, send you out, know how to treat TB. And then next group of patients were coming in, and they had this rare pneumonia, pneumocystis pneumonia. And like, pneumocystis, I got to look that one up because I don't see it every day, right? But I look it up, it's in the book, I know how to treat it, write the prescription, send them out, right? And then they were coming in with this crazy skin lesions, Kaposi sarcoma, this rare skin cancer. And they say, oh dang, Kaposi sarcoma, I'm going to have to refer you to a colleague, right? Because I don't know how to treat it, but I know someone who does, right? Refer you to my colleague. They got you sorted, send them out. And what happened? Patients kept on coming back. And when they came back, they were sicker and sicker and sicker. Why? Because what we were treating were just the symptoms, right? We needed to look at the biology to understand the root cause. And when we understood that the root cause was not only a virus, right, but a retrovirus, and we figured out how to develop antiretrovirals, right, the mortality rate from HIV/AIDS went from a mean mortality of 6 months. That means that 50% of people were dead 6 months from diagnosis, right? To now, where the standard survival after diagnosis is greater than 50 years. We did that in my lifetime, right? But the key to that was understanding the biological mechanism. And when we use the biological mechanism, we target that, right? Then we can achieve transformative change. So when it comes to how ACEs leads to morbidity and early mortality, right? That's why, for me, I get so excited about the mechanism, because that's where the solutions are. And ultimately, it all comes down to our biological stress response, right? Our fight or flight response, and it works a little something like this. So imagine you're walking in a forest and you see this guy. Did I scare you? Even a little bit. Anyways, right? What happens? What happens, right? Our amygdala, which is our brain's fear center, sounds the alarm, right? And it activates our fight or flight response. So we release all these stress hormones like adrenaline and cortisol. And so our hearts start to pound. Our pupils dilate. Our airways open up. We shunt blood to our large muscles for running and jumping, and away from that itty bitty muscle that holds our bladder closed, so we may pee our pants. No judgment, right? But we are ready to either fight that bear or run from the bear, right? But if you were to think about it, fighting a bear wouldn't seem like a good idea, would it? No, because look at him, he's big, he's got teeth, he's got claws. And that's why when we activate our fear response, our amygdala also sends projections to this part of the brain up here, the prefrontal cortex, that regulates executive functioning, things like judgment and impulse control, right? And turns it way, way down. Because you don't want impulse control getting in the way of survival, right? And instead what it does is it turns up the noradrenergic nucleus of the locus ceruleus, or as I like to call it, the part of the brain responsible for, I don't know karate, but I do know crazy, right? This is our within the brain stress response, and it gets us amped up. And the less obvious thing that happens when we activate our stress response is that it also activates our immune response, right? Because when You activate, if that bear gets his claws into you, you want your immune system to be primed to bring inflammation, to stabilize that wound so that you can either live long enough to beat that bear or get away. It's brilliant, right? It was designed over millennia to save our lives from a mortal threat. But the problem is what happens when that bear comes home every night. And this biological process is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. And children are especially sensitive to the impact of high doses of adversity because their brains and bodies are just developing. So high doses of adversity affects the developmental trajectory of not only the brain, right, but also the immune system, our hormonal system, and even the way our DNA is read and transcribed, something called epigenetic regulation. And although the original ACE study was done in an adult population, asking adults which of these you've experienced before age 18, we now know that this biological response, right, the toxic stress response, signs and symptoms are evident as early as infancy, right? So in babies, we see developmental delay, growth delay, failure to thrive, sleep disruption. As kids get a little older, we see increased risk of asthma, pneumonia, viral infections, right? Atopic diseases like eczema, learning difficulties, behavioral challenges. And as they head into adolescence, we see increased risk for things like obesity, diabetes, headache, abdominal pain, teen pregnancy, hyperthyroidism, autoimmune disease, right? Pubertal changes. And here is the kicker about toxic stress, is that it has an intergenerational impact. The ACEs that a girl experiences impacts her later prenatal and perinatal outcomes. That toxic stress response can lead to an increased risk of preeclampsia, impaired fertility, alterations in, the microbiome, all those trillions of bacteria that we're covered in, right? That is passed from mom to child along the birth canal. We can see changes in that microbiome. Impacts on maternal risk behaviors, right? The likelihood that mom will drink or smoke or use substances during her pregnancy, or maternal chronic diseases like heart disease or diabetes. And we see an increased risk of fetal loss, preterm birth, and low birth weight. Okay, so now that we understand what's going on, we understand the toxic stress response, right? And mark you, we recognize that although ACEs are clearly risk factors for developing a toxic stress response, we also know that there are other risk factors for developing a toxic stress response, like discrimination, right? And we now understand, wait, this is all one biological mechanism. That the higher the dose of cumulative adversity, the greater the risk that that stress response will become overactive and lead to long-term changes in health, right? So what do we do about it? Well, the science also shows us that that toxic stress response occurs along a spectrum, right? Remember that our stress response was designed to save our lives from that bear in the woods. And when we look and recognize that the stress response can be a positive stress response, where you have brief activation of the stress response, short-term elevations in heart rate and blood pressure and hormonal levels, right? But then the body restores itself. Or what we see, a tolerable stress response, which is when you have a more severe stress, but it's time-limited activation of the stress response, right? But here's the key. This right here. Homeostasis, right, that biological balance, recovers through the buffering effect of a caring adult or other interventions, right? But we kind of knew this, right? Because, listen, my husband and I, we got 4 boys. Yes. And what happens, pray for me. What happens, like, when we're out on the playground, something scary happens, right? Or even something like real serious happens, right? Because we know that stressful events don't only, they're not only happening in certain populations, they happen in all of our families, right? But when something really scary or difficult happens, what is the first thing that we do almost intuitively, right? As a mom, I wrap my arms around our boys and I help them feel safe and I let them know that it's okay, right? And I help them understand and make meaning out of what's happened. And when I snuggle them up and give them love and hugs and kisses, which fortunately I'm still able to do, the little one is 3, still able to get lots of kisses from him, 7-year-old. Actually, he's pretty snuggly. The big ones, not so much. So what happens when I do that to our boys? It releases in their body oxytocin, right? And you all done the maternity care rotation, right? Oxytocin, this is a drug we use in healthcare all the time. We use it to induce labor, right? And it turns out that oxytocin biologically buffers the stress response. Because just as our bodies evolved a biological process to keep us safe and alert us in stressful situations, our bodies also evolved a way, right, to restore homeostasis after that stress response has been activated. And in fact, what we see is that there's a lot of science around this. We see that nurturant caregiving, right, when kids are, they did a study in institutionalized children who were randomized into high-quality nurturant caregiving, right? And it's can I say how sad it is that kids need to be randomized into high-quality nurturant caregiving? But in any case, right, what they found was that on MRI studies, the kids who were randomized into high-quality nurturant care showed normalization of the developmental trajectory of the white matter structures in their brains, right? Nurturing relationships are healing. We see that things like mindfulness and meditation helps to regulate our immune system. We see that social support protects against the rise in infection risk associated with frequency of conflict. We see that oxytocin, right, our snuggle hormone, not only inhibits the stress response, enhances bonding, it protects against stress-induced cell death. It has anti-inflammatory effects. It enhances metabolic homeostasis. It protects your vascular endothelium, right? The lining of the inside of your arteries, right? Where, plaques can develop. Literally, it is protective. And we see that in studies in rats, because this is across species we're seeing this. In studies in rats, have you all heard that lick your pup study? Right? I love this study. Michael Meany did the study where he had these rat moms, and they had their pups, and some of the rat moms did lots of nurturing, caregiving, right? This licking and grooming behavior. And some of the moms, not so much, right? They were low licking and grooming. And what they found was that those rat pups who got lots of nurturant caregiving, they had a more healthy stress response system that turned itself off more normally after it had been activated. They performed better on cognitive tests, right? They had better recovery in stressful situations. And all of that, it turned out, was mediated, right? It was controlled by changes in their epigenetic regulation. So not the actual sequence of their DNA, but it turned out that that nurturant care behavior, right, actually led to markers being placed on top of the DNA, this epigenetic regulation, meaning above the genome, that coded for how the DNA about the stress response system was transcribed, right? And the difference in that transcription to say, hey, your stress response should be very, very sensitive and very reactive, versus like, nah, you're okay, right? And your stress response system doesn't have to be so much of a hair trigger, right? And guess what? Here's the crazy thing. It's what I love about this study. They did something kind of nuts. With the next generation, they found that these epigenetic markers were handed down from generation to generation. But with the next generation, what they did was I don't know if Michael Meany was watching too much Lifetime television, right? But with the next generation, they actually took the pups and switched them at birth, right? And what they found was that the pups who were biologically from a mom who did low nurturant caregiving, right? But when they were raised by a mom who did lots of nurturant caregiving, guess what happened? They performed better on cognitive tests. They had a more normally functioning stress response system. And it turns out their epigenetic markers were that of their rearing mother, their foster mother, not of their biological mother, right? Literally, these interventions, and especially nurturant care, has the opportunity to heal down to the epigenetic level. So y'all don't have to read the 20,000 studies that my team and I read, but the summary is right here, right? Essentially, what we see is that sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships all help to address the biological mechanisms of the toxic stress response, right? They reduce stress hormones, they reduce inflammation, they enhance neuroplasticity, and they help to regulate epigenetic expression, right? And what we, for the first time this year, the National Academy of Sciences, Engineering, and Medicine, right? This is kind of the highest standard of scientific evidence, released a consensus report. And what that consensus report recommends is that health professionals adopt and implement screening for trauma and adversities early in life to increase the likelihood of early detection. And this should include creating a rapid response and referral system that can quickly bring protective resources to bear when early life adversities are detected through the coordination of a cross-sector response. And the committee goes on to say, right, once adversity or trauma occurs, it can't be erased. However, its effects are not destiny. Effective services can help to mitigate the impact of adversity on health across the life course. That is what the consensus of evidence shows. And you guys, we've done this before. It turns out in the US, one of the things that we're really good at is public health initiatives, right? You heard me talk about HIV/AIDS, right? When it comes to smoking, right? Instead of looking downstream, right? The Surgeon General, when they issued the 1965 report on smoking in the United States, they didn't take on, you know, heart disease specifically or emphysema. We're seeing these, you know, high rates of heart disease, emphysema, cancer, like all these different outcomes. God, how are we going to tackle all that, right? Let's get to the root of the root. What's the root cause? Smoking. This is what has happened in the United States in smoking between 1976 and 2018. And I want to specifically highlight the last 2 decades, right? Between the late 90s, when teen smoking was at 25%, to where we are now, 3.6% doesn't include vaping. Oh my God. 3.6%, right? Because it turns out getting people to quit smoking is really, really hard. But non-initiation, effective campaigns to prevent youth from starting smoking to begin with, has been the single biggest driver in the reduction in smoking and tobacco-related illness in the United States of America. We can do this, right? Let's look at maternal mortality. I was talking to a few of the students earlier, and I talked a little bit about what we've done with maternal mortality in our state, right? This is something I feel particularly proud of. I didn't do it, but now I work for the government, I can take credit for it. So when we look at maternal mortality in California, right? This line here is California, this line here is the US. What happened in 2007? In 2007, there was a public-private partnership between the Department of Public Health and private scientists and researchers to create something called the California Maternal Quality Care Collaborative, where we systematically tracked the outcomes, the maternal mortality outcomes, and drove best practices. And between 2007 and 2013, there was a 55% reduction in maternal mortality in California. We went down to 7.3%, while nationally, the maternal mortality rate has continued to rise. That is what a coordinated effort can do. Here in California, I am very pleased to announce that as our first Surgeon General, listen, I come in, I go big or go home, right? California has set a goal to cut ACEs and toxic stress in half in 1 generation. We did it for smoking, we did it for maternal mortality, we're going to do it for ACEs and toxic stress. And how are we going to do it? We're going to start by establishing primary prevention through a coordinated public awareness campaign, right? Because when we raise awareness, we know this, right? When we know better, we do better. We systematically deploy broad-scale screening for early detection and early intervention of ACEs and toxic stress. We interrupt vertical transmission, right, the transmission from parent to child, by advancing screening in children and adults, right, with a special focus on the prenatal and early parenting years. And we coordinate and strengthen the network of referral and treatment systems to make them more effective, accountable, and easy to navigate. And for once, right, this is not an unfunded mandate. Beginning in January of 2020, any primary care provider who is caring for a Medicaid, not Medicare, that's over 65, Medicaid population who screens kids or adults for ACEs for the first time is going to be reimbursed, is going to be paid for that screening. Right. And Governor Newsom put $40 million behind it, right? So we have $40 million to reimburse providers for screening. And not only that, another $50+ million to train providers on how to screen and how to respond with trauma-informed care, right? We are doing this. My team in the Office of the Surgeon General has brought together leading experts in the field who have developed a simple 2-hour online training that covers the basics of how providers screen for ACEs and how they respond, when they have a positive screen, including also how to bill. But listen, we may have developed this for Medicaid providers, but you don't have to be a Medicaid provider to take the training. Go ahead, all y'all, starting in first week of December, just go right ahead and take that training if you want to. Simple 2-hour online training to establish a floor of what we all know in terms of how to screen and how to respond with trauma-informed care. And then the phase 2 of that is really provider engagement with deeper levels of training in partnership with organizations like the California Medical Association, the American Academy of Pediatrics, the California Academy of Family Physicians, a lot of these specialty associations, NAPNAP, right, the National Association of Pediatric Nurse Practitioners, to be able to make sure that we're doing these trainings that are relevant to each of the specialties and each of the disciplines. And as we're looking at the response, right, we look at what are the key principles of trauma-informed care. Number 1, establishing the physical and emotional safety of patients and staff, right? Just as each of us know to wash our hands before we touch a patient, because germ theory is no longer just a theory, right? We recognize that that is the mechanism of transmission. Similarly, we also understand that as we move into doing this work, right, that there are best practices for staff to avoid vicarious traumatization, right? To support ourselves in doing this work, and also to engage in our patients in a way that is trauma-informed and resists re-traumatization. Building that trust between providers and patients. Recognizing the signs and symptoms of trauma exposure on not only psychological and behavioral health, where I feel like it's maybe more recognized, but also on physical, you know, what we call, I love that we have the separation, but physical health as well, right? Like a child who has 4 more ACEs is twice as likely to have asthma. But when they come in with asthma, do we recognize that what's happening in their environment may be playing a role in their health condition, right? So understanding what conditions are associated with ACEs are really important. Having that patient-centered, evidence-based care, training providers and staff on how to collaborate with patients, right? And ensuring that collaboration, in doing that collaboration, we're bringing patients into the treatment process and discussing mutually agreed upon goals for treatment, right? And finally, providing care that is sensitive to the patient's racial, ethnic, cultural, and gender identity. These are all the fundamentals of trauma-informed care. And as we move forward in the next phase of this work, right, the other thing that we are doing, because we recognize that just as, you know, HIV in the 80s, nobody had ever heard of it. It was a totally new field. And we've gone from there to, you know, every major medical center has an HIV specialist treatment team, right? Similarly, we are creating a field. And one of the things that the Office of the Surgeon General is doing in partnership with the Department of Healthcare Services is we are actually creating a learning and quality improvement collaborative, a statewide learning collaborative in up to 50 clinics in 5 regions around our state to really understand and establish what are the best practices, right? To collect data, to look at how do we do this, how do we respond, and which of these practices are associated with the best outcomes for patients, right? And not take that learning and then share it with y'all, right? Disseminate those best practices so that we can learn together as a field. But I think that one thing that we recognize is that we, as healthcare providers, we are on the front lines of doing the early detection and early intervention when it comes to the impacts of early adversity on health. But if we think that it kind of, begins and ends in the exam room, right? I know that I'm seeing all these heads shaking in the audience, right? Like, I know you know, right? That we would be mistaken. And this is one of the things that the national academies identified in their consensus report, right? What they identified was all of this biological response that I talked about, the toxic stress response, that sits in the middle. That's the biological effect pathway, and it interacts with the socio-behavioral effects pathway, right? They dramatically influence each other. But what happens in our bodies is shaped by what's happened in our families, right? This is what the last several decades of science is telling us, is that our environments influence our biology. Whether we get nurturant care impacts how our DNA is read, right? And factors like family cohesion, social connections, and caregiver well-being, right, profoundly impacts these biological factors. Because if there's any parents in the audience, or you don't have to be a parent to know this, but like we know, when something happens with my little one, my capacity to sit with him and throw my arms around him and be that safe, stable, and nurturing buffer for his stress is totally dependent on my well-being and my stress level, right? And these things are shaped by all of these factors, including our living conditions, our healthcare system, our early care and education. If folks have access to high-quality mental health services, right, that impacts their ability. Listen, if someone's managing a chronic mental health issue, if they're able to get access to high-quality care to make sure that their condition is well managed, that profoundly impacts their ability to be that caregiver, right, which impacts their child's biology. And all of this is impacted by structural inequities and socioeconomic and political drivers, right? We recognize this. We get this. And so when we look at what our responses are, we recognize that our responses have to go beyond the exam room. That we as healthcare professionals and as healthcare leaders have an opportunity every day in the work that we're doing in the delivery of care. But one of the dope things about being a health professional is that we're also leaders in our communities. And we also have the opportunity to shape the agendas, right, of what happens around us. Each and every one of us has the opportunity to go home today, right, and if you're part of the PTA, find out what your child's school is doing in terms of trauma-informed and trauma-sensitive educational practices, right? We have the opportunity to share this information on social media and be part of raising awareness about these issues. And guess what? People believe us because we're healthcare professionals, right? We got that cred. When I started in my role, one of my favorite things was starting off with a statewide listening tour. And I traveled all around our state. I went down to the border. I went to our rural Northern California counties. I went in, into the Central Valley, Inland Empire, went urban, rural, you name it. It was awesome. And some of the things that I learned as part of that listening tour, first of all, what I kept on hearing over and over and over again, whether folks were dealing with homelessness, whether they were dealing with helping families out of poverty, trying to support economic development, whether they were dealing with the opioid crisis or recovery after natural disaster, in every community, what I heard over and over and over again, right, was that trauma was impacting the ability to be successful in doing this work in the communities, right? So people recognize this as a root cause. And I was also struck by how many folks are already rolling up their sleeves and are already in it. They're already doing this work, right? Which is phenomenal. It actually blew me away. But it also highlighted the need for coordination, right? That was critically important. The need for coordination and infrastructure, because there's so many folks who felt like they had to reinvent the wheel. And having the opportunity to see all of the amazing work that happened really made me help to recognize that, like, we don't have to reinvent the wheel. There are amazing best practices that are happening around our state. I literally just read a news article about a pilot program that's happening in Yolo County and Stanislaus County, where first responders, right? If you're a paramedic, if you're a police officer, if you're part of the fire department and you're responding to an emergency situation and there's a child on scene, they actually have a program where they're able to get the child's name and information, and without communicating any confidential information, transmit that information to the child's school and say, this child was on scene at a traumatic event yesterday. Handle with caution. They're going to need a little bit more TLC, right? These are the types of connection and infrastructure, right, that creates a systemic and societal coordinated response. That is the thing that is going to get us to cutting ACEs in half in a generation in California. One of my favorite things that I have done since coming into office was I had the opportunity to convene the ACEs reduction leadership team. It turns out when you're the Surgeon General, you put it out there, people come, right? And it's a collective effort across the Newsom administration to create a multidisciplinary plan to cut ACEs and toxic stress in half in a generation. I had the opportunity to meet with leaders in all of our Health and Human Services Department, with the Governor's Office, with the Department of Education, with law enforcement. And as I sit down, I and my team sit down with each of these leaders, and listen, I'm not suggesting to them, they know their work better, far better than I do. And I said, what can your team do to be part of cutting ACEs in half in a generation? And it is amazing to see what so many folks are bringing to the table, the innovation, the ideas. I'm really, really excited about this. And a lot of these will be put together into a report that's going to come out in late-ish in 2020, Surgeon General's report on ACEs and toxic stress in California. But some of this investment is already happening, right? We saw the governor and the Newsom administration put $195 million into early learning and care workforce, $50 million into school education and safety programs, $31 million, which is connected to $125 million ongoing to increase access to state preschool, right? All of these are part of these concentric circles of buffering care. Because I'll tell you what my not-so-secret dream is. Just as we know that the cumulative dose of adversity is what leads to the harm and the health and social risks, so what I want to do is increase our cumulative dose of buffering across our society, so that every educator, every health professional, every bus driver, the dude that's working the checkout at Safeway, right? Everyone, all of us, we all recognize our role in being part of this network of buffering care, right? We can actually do this. And when we look at building this infrastructure of buffering care, right, as we're raising awareness, as we're putting this information not only into our practices, but also in our policies, right? That is how we're going to get to this place. And what it's going to take is every single one of you, right? Because there's no one person, there's no stroke of the pen that happens in Sacramento, right? There's no, the most powerful tool that I have as Surgeon General of California is y'all, right? Hopefully the ability to inform and inspire and offer some tools as to how we're going to get there together. And then you all do the hard work every day. And I'm going to step out for a second here and say, as we all are doing this hard work every day, I want to strongly encourage you, right? Again, when we're talking about ACEs, we're not just talking about those folks over there. We're talking about us. And I want to encourage each of you to practice that self-care, right? Self-care isn't selfish because we need you. We need you in this fight. When we look at how long it took to address smoking, when we look at how long it took to address maternal mortality or HIV/AIDS, we recognize that it takes decades. When we're talking about cutting ACEs in California in half in a generation, right? That's 20 to 25 years. And we need each of you to be in this fight, to be in this struggle to advance our practices to cut ACEs in half in a generation, because this is long work. So whatever it is, if it's going for that walk, if it's doing that Headspace app or whatever it is, right? If it's connecting with our loved ones or establishing our systems, right? So literally, I know people who literally have a list, who write it down, right? Of what are my sources of buffering care? What do I do for self-care that's going to allow me to make sure that I have my oxygen mask on, right? So that I can be there for others. I want to encourage you all to do this for yourselves. I want to thank you for the work that you do every day. And I will have to say, when we get to that day, when it's 20 years from now, we've cut ACEs in half in a generation, there's a party at the office of the Surgeon General. I will see you all there. Thank you. Thank you. And I think that we have time now for some questions.
Absolutely. So now is our question and answer portion. If you have filled out the index cards, please put them or disperse them outwardly so that we will come by to the ends of your rows to pick them up and bring them up to Dr. Burke Harris. Yep, outward. There we go. And we'll come by and pick those up and get those to her.
All right. We have a couple of questions here already. First question. What can we do to assist the complex trauma and toxic stress on systems that are trying to provide coordinated care initiatives for clients or staff with high ACEs scores? And there's a little insert here. Maybe systems, maybe broken systems, some of the systems. So one of the great pleasures that I have in doing this work is working with a lot of experts who are leading these efforts, who have the opportunity to work with and support. And One of these experts from San Francisco have you guys heard of the Trauma Transformed initiative? There's actually a 7-county initiative here in the Bay Area called Trauma Transformed. And one of the things that it looks at is how do we address the ways in which trauma is oftentimes embedded in our systems, right? And this is where having trauma-informed policies and practices it's really critically important. It's important for us to know the information and to know about trauma-informed care, but it's also really important for us to understand, like, look at our policies and practices and say, hey, how is this reflected in how we do things, right? And this is the transformative work that we have ahead of us as we're looking at our systems and practices. So some of it is even around, do we have capacities for staff to do the self-care, right, that we know is important? Are our policies and practices, are they harsh and punitive, right? Or do they reflect an understanding of trauma-informed care and what that means and how we can better implement them? And so I will say, in terms of what we can all do to assist in this process, is really to be a voice, raising the best practices. There's actually a lot of evidence about this, and I would refer folks to the report from the National Academies of Sciences, Engineering, and Medicine. They did a fantastic, I know all of you will read all 500 pages as I did. But no, really, there are a lot of best practices out there, and it's transforming our care really requires transforming our systems as well. So there's a lot that we can do. Okay. Given your experience in working with communities, what are the top 1 to 2 things that you suggest to those of us who want to do similar work in our local communities, i.e., what are the mistakes and pitfalls to avoid? Great question. People always talk about what goes well, and it creates the illusion that it's just this linear path of success when all of the mistakes and challenges are there. So a lot of this is reflected in some of the clinical protocol for screening for ACEs that actually we've put together and we're making available on the ACEs Aware website, right? Do we have www.acesaware.org? Soon. First week of December, right? So one of them, my experience was I've tried screening for ACEs every which way from Sunday. I've tried verbally asking the ACEs question. I've asked doing it in a written format. We did a randomized controlled trial looking at it in tablet format in partnership with Benioff Children's Oakland, like all of these different things. The thing that I will say, which fortunately now there's some evidence to support, is that when the screens become available on the website in December, it's available in 2 formats. One is an identified screen where you ask the patient which ACEs they've experienced, and the other is a de-identified screen where you say you don't have to tell us which ones you've experienced, only how many. The de-identified screen was such a huge breakthrough in doing routine screening for ACEs in primary care. Because what it gives the primary care provider is enough information to understand whether that patient is a high risk, intermediate risk, or low risk for toxic stress, to be able, and then connect them to the resources that they need, without the patient having to disclose, right, in a 15-minute visit, which is really, really difficult to contain, right? And then also, it allows that. It's not that we never understand which ACEs a patient has experienced, but that understanding comes in the context usually of if the patient is referred to a mental health or social work visit, right, then that individual who has more than 15 minutes, right, and specialized training can then unpack that ACE score. And at the same time, have the capacity and the resources to connect that patient or that family to the services that they really need. That was such a breakthrough. It was such an important piece. And that learning, I've done it a lot of ways, and it was really, really challenging in a lot of different ways. So that was a learning. That one is free. And some of the other pieces, I mean, you heard me talk about the self-care. Like, that is not an academic exercise. When I'm talking about self-care, I feel like it's so critically important for us to support that learning that self-care isn't selfish, because I think a lot of us in the health professions, we come to it because we're healers, right? We're the ones who are often tireless and selfless and all of the above. And in order to be here, to be doing this work for a long time, because we have such a risk of burnout. We have such a risk of really having challenges, especially with all the stuff and drama that happens in our own lives, right? That the self-care piece feels really important. So those would be the two biggest learnings. There's another question here. Will the ACE screening online training in December include ACE categories such as deportation, discrimination, foster care, etc., or will it only have the original 10 categories? Great question. So the tool that we're using for pediatrics is the PEARLS tool, the Pediatric ACEs and Associated Life Events. There's one piece that I want to clarify, right, which is that although factors like deportation, discrimination, foster care, et cetera, well, not foster care, because foster care means you're not being raised by your parent, right? But discrimination and deportation, although those are risk factors for toxic stress, and we recognize that's the same biological mechanism, it's really important that we recognize that they are not considered ACEs and they're not added to the ACE score. And here's the reason. They are little a, little c, little e adverse childhood experiences, definitely, right? But big A, big C, big E ACEs are referred to the 10 criteria in the Kaiser CDC study. And the reason that's important is that when we look at those, 9 out of 10 leading cause of death in the US, and we look at some of the odds ratios, some of the science behind it, we only have those odds ratios. We only have standardized set of odds ratios for the traditional ACEs. And when we look at things like deportation, discrimination, they've been studied in lots of different ways with lots of different criteria. And so there's not a standardized set of, oh, if you have 4 or more ACEs, your relative risk of ischemic heart disease or your relative risk of asthma is X. And this is a place where it's really, really important for us to be extremely rigorous with the science. Because I guarantee you, somewhere out there, there's someone saying, oh, that ACEs stuff is bogus, right? Oh, why are we dedicating all of these resources, over $100 million, all this stuff in addressing ACEs when, there's not really, is it really a strong association? Who knows? And that's why we have to be on point to say, okay, when we're using these criteria, here's the relative risk. We're including discrimination, deportation. The relative risk looks a little bit different, but it all acts through the toxic stress pathway, and that's what we have to treat, right? That's what we have to prevent and address. So that piece feels really critically important. But to answer the question, yes, the PEARLS, the pediatric tool, includes the 10 traditional ACEs, and then also 7 to 9 additional social determinants of health that we recognize are also risk factors for toxic stress, and they're scored differently. So that's Yes, and. Okay, but you just gave me 3 more questions. Okay.
A lot of good questions.
Let me read really quickly. God, there's so many questions. Okay, I'm picking one. How can we / juvenile delinquency court system help in cutting ACEs in half? I'm a public defender for juveniles in Sacramento looking for help. Woo, that's a good one. So in my first day on the job as Surgeon General, I attended a press conference with the governor where he announced the plan to move the Department of Juvenile Justice into the Department of Health and Human Services. And we're in the middle, where you know, that transition is going to take about a year. We're in process on that right now. And it comes with a recognition, right, that when we're looking in the juvenile justice community, listen, that's where we're seeing the highest rate of ACEs, and that's where, frankly, the vast majority of kids who are engaged in the juvenile justice system are demonstrating symptoms of a health condition, which is the toxic stress response. And this is where, as far as I'm concerned, our juvenile justice population is like a high risk community. And that is a place where we need to be applying all of the lessons that we're learning from the science, right? Around, number one, how do we look at training and education? One of the things that, for whoever wrote this question, one of the most important things that we can be doing straight out the gate, it all starts with a baseline level of education. Because when we educate our colleagues about the impact of ACEs and the impact on brain development, on the prefrontal cortex, all of the above, then it allows people to be able to see behaviors and actions of young people differently, and to see our role in addressing them differently, right? A couple years ago, I did an initiative called the Positive Youth Justice Initiative. Before I was in my current role, when I was working at the Center for Youth Wellness, and one of the things that we were doing was training and education for administrators and officers in the juvenile probation system. And then, no surprise, what happened in the juvenile probation system is that when we did this education for officers, before they could even apply it to the population of young people that they were working with, like everyone, they looked at themselves and found really significant rates of ACEs. And one of the great things about this work is that when we understand the biology of toxic stress, it gives us an opportunity to have some self-compassion, right? And then also empathy when we see others who are also demonstrating the symptoms of toxic stress. And then the next thing that they did was, in the counties, in the 7 counties that were part of this initiative, they moved forward with implementing changes in their policies and practices. It's about education, policies, and practices. That is what we can do in the juvenile justice system, in our healthcare system, in our education system, in every system. That is how we do this work. Thank you.
Hello.
Thank you, Dr. Burke Harris, for your presentation and answering our questions. This ends our program for today. And I thank all of you for spending your afternoon with us. It looked like everybody was getting in some great information, feeling affirmed and validated, but also ready to go out and change the world and become those buffering folks for everybody out there. And I appreciate all of you coming today. There are some refreshments in the lobby. Just a few left. No, I'm kidding. But there's a little bit out there, so please have a sandwich, some chips, water on your way, and feel free to mingle in the lobby area. Oh, and please complete your evaluations. I will also be emailing a link as well, but if you have a paper evaluation, that would help. Oh, and for those of you who want to CE hours, there is a table that will have your certificate.